Dr. Denise Ejo, the CEO of Cornwall Cancer Foundation. I would like to welcome you to our Cornwall Cancer Foundation page. Our goal is to create an awareness of the challenges, support and guidance experienced in managing cancer care for sufferers, family, carers and friends. To engage with us, don't forget to subscribe to our channel. Click our notification bell.
Be discussing pain and symptom control options dealing with cancer, and she'll be doing this with palliative medicine specialist Dr. Ebun Abashi. Good morning, Dennis. Doctor, good morning.
Good morning. How are you today?
We are doing great. Good morning.
Okay, well
all right,
done.
So the awareness continues. Let's now yield the floor to you.
Thank you very much. Good morning, everyone. Good morning, viewers, and welcome to another edition of the Kaki Cancer Awareness Program. Today in the house, we've got Dr. Ebun Abashi. Please, Dr. Ebun, can you put your mic on? Your mic is not on. Dr. Ebun, can you hear us? Can you put your mic on? Your mic is not on.
Yeah, good morning. I beg your pardon. Good morning. Good morning, Denise, and good morning, viewers. Yeah, it's a pleasure and a complete privilege to be here with you today. Thank you for the kind invitation. Yeah.
Thank you for coming on board and for being part of this. So I'm going to read a brief bio about you, and then we can hit the high road. So Dr. Ebun is currently an associate specialist doctor in palliative care. She holds a doctorate in a university. I can't pronounce the word. That's why I'm not attempting it, because it's in the Netherlands. So I don't want to embarrass myself. And also works in a hospital, especially a hospice in the UK. Dr. Ebun's specialism requires her to have multidisciplinary care provision. It also affords the opportunity to offer hope and care for people who are unwell, their families, friends and loved ones. As we talk about palliative care, Dr. Ebun supports patients with difficult symptoms regardless of their age, diagnosis or settings, that is at home, hospital or hospices. And she is a private advocate and the CEO of Palliative Partners, which is a non-profit NGO. Dr. Ebun, thank you for joining us today. I'm very mindful of the topic we're about to talk about, which is palliative care. And I think almost every cancer patient or people with who are very ill, end up having to do not want to talk about this. But we have to talk about things. If we're going to talk about awareness, we have to try and address all areas and educate the populace about what goes on and what to expect. So I'm going to say a very big welcome to you again, and thank you for agreeing to join us. And just for the purpose, Dr. Ebun is actually my classmate from secondary school, so I will most probably refer to as Ebun in most of the conversations. Dr. Ebun, thank you for agreeing to join us as we go and hit the high road with the questions I've got for you. Can we start now? And my question starts with, can you give us a brief overview of what palliative care means?
Thank you very much, Denise. Well, I'll start with the root word, to palliate. To palliate simply means to make better. To make better something that, of course, if it was all nice and rosy, you don't need palliate. So it's really about improving. It's really about making things better. It's about dignity. It's about comfort. And to give you maybe a well-summarized definition, palliative care is that medicine, that seeks to improve the life of patients who have very difficult symptoms. Historically, it had been affiliated, or it had been associated with cancer. Yeah, because that's actually the history of palliative care, and we might talk about that a little bit further on during today's meeting. But over the years, research has shown that some patients that have other diagnoses have symptoms that are equally challenging. And if you were to put a measure on such symptoms, then such symptoms and such patients deserve to have palliative care. So palliative care has been opened up to patients that have what I would call difficult refractory, difficult to treat, disturbing symptoms that usually recur and that make life just, unbearable in some instances, very, very unbearable. And the idea is, yes, this patient might be, the disease might be incurable. Yes, this patient might be going towards the end of life. We usually believe that nobody knows when that final date will be, but it's about living well until the very end. And as a Nigerian, I guess I would also add in the definition that the Nigerian context has actually made palliative care easier to define, because during the COVID, people were talking about palliatives. So in the context of Nigeria, people understand that when you give palliatives, whether it is a pack of food or whatever, you're trying to make their symptom or their situation better. Thank you.
Thank you for that, but no, I'm not taking that one. What's that? Palliative food and palliative care.
I don't know what is going on in Nigeria when I started hearing palliatives, but it's actually a right way, to say this is what it's all about. It's not in the context of COVID, it's not in the context of living, but now it's in the context of disease management. Thanks, Denise.
Thank you. I have to laugh about that one because I was a bit shocked. Actually, I found it very, very annoying when I first heard it. But let's move on. At what stage of cancer is palliative care needed, and what does that mean for patients?
Yeah. So again, the spectrum of palliative care can cover as wide a spectrum of a person's disease trajectory as is required. If I'm to define palliative care as the World Health Organization has defined it, it is actually providing systematic medical care that focuses on at least 3 dimensions of the patient's life. We are focusing on the physical aspect, we are focusing on the psychological and emotional aspect, as well as the spiritual and every other thing that is important. The reason why I mentioned the definition is that means that sometimes, even at the point where the disease, the diagnosis is mentioned, we have people that once they're told that this is the diagnosis and this is the prognosis, they go into a complete shutdown. So from that point, they could benefit from palliative care. It's not all about, the terminal end of the disease. It's about accompanying this patient, who is a human being, in their journey. So as much as is required, there are times when, you don't really require much of an input, but there are times when you require an input. So it's actually being ready to provide that input as and when it is due.
Now you've made it very easy. Thank you very much. Now I can now understand your English, right? All right, then let's move. What does palliative care involve, and what support is available, or what support do you know is available in Nigeria for palliative care patients and their families, based on your knowledge? Because I'm very mindful of the fact that you do practice outside Nigeria.
I'm far away from Nigeria, but I'm in touch with Nigeria. So, like I mentioned, palliative care is holistic care. It's about thinking about the whole person, and it's about providing for that person and the people that are important to the person, because one person can affect every other person. And within the Nigerian context, Nigeria is not alone in the changes that have come to become the normal in the family setting. Traditionally, you would have a family setting where probably the children will look after their parents, or people look after themselves within a social context. But the family structure is constantly changing. Over the years, the family structure, there's been lots of migration, even in the UK and in large countries all over the world, but particularly in Nigeria, such that a lot of people are isolated for different reasons. For socioeconomic reasons, people would have traveled away from home. So you might even have a family where both parents are in Nigeria, maybe all of their children, for purpose of example, are doctors, but they are abroad, or they don't live in the same city with them. So you might have a situation where such people that are facing this difficult circumstances as a result of their illness, advanced disease, they are isolated. Many people, they get back and they depend on their neighbors. If you have good neighbors, they might depend on their communities, religious communities. Many religious communities are still able to participate in people's treatment journey. So whether it's the Muslim community, the Christian community, or what have you, and more, this care is isolated. If you are not careful, such people might just go on their journey alone and die, not just as a result of their illness, but miserable as a result of everything else that that has been related, that has accompanied their situation. So it's about ensuring that there is that holistic care, there is that holistic and individualized care. So you might have people having the same diagnosis, the same age, but different needs, needing different things. One particular person might have, a complete family network where everything is provided. They might even have family abroad sending diapers, sending medications, and so on. And you might have another family, same situation, but that doesn't even know that palliative care exists, talk less of being able to tap into that resource.
Thank you for that. I'm going to come back to you on that question again, and I think we might be able to cover it somewhere else. How do patients and their families cope when palliative care means end of life? Because from what you've said now, and I'm trying to look at it carefully, is it doesn't necessarily mean end of life, but it is associated with end of life. It is linked. A lot of people, when you hear palliative care, all you think about is end of life. But from what you are saying now, it doesn't necessarily mean that. So now I'm asking the question, when it does mean that, how do patients, you get it. So the first part you've done is when it doesn't mean that. Now we're saying when it does mean that.
Yeah, okay. Usually with this question, I would have done a slide. I would have shown you the trajectory. Is care that is provided. Some patients, might benefit from palliative care for a span of 5 years. Every time maybe they are receiving oncology treatment, they are receiving palliative chemotherapy, radiotherapy. That is some aspect of, the care that is being given. Maybe with their treatment, they have very, very bad vomiting, refractory vomiting, that is part and parcel of their treatment. Depending on what oncology treatment they are on, they might have palliative care involvement. And then once the symptoms resolve, then that is withdrawn, or that is kind of minimized, because it's not required. But what you just asked now, which is the end of life, is when the patient is actually approaching the end. Now, by definition, especially if we're using the gold standard framework, which is a recognized framework for defining and for contextualizing, by definition, the end of life period is the last 12 months of life. Now, Denise, both of us know that it will require more than a crystal ball to be able to say this is exactly the last 12 months of Mr. Jones's life, or Mr. Smith's life, or Mr. Emeka, or Mr. Mrs. Adebimpe's life, as the case may be. So it is just an estimate. It is an estimate mainly for planning. The whole idea is that having that aspect of the care allows people to plan. It allows the practitioners to plan. It allows the patient themselves to plan. And it allows the families to plan. Do you know that many times in retrospect, I've heard families say, oh, if only we knew this person was dying. If only we knew that this was going to happen this way. But many times what they are saying that they didn't know, the medical practitioners could have predicted. Yes, we might argue that, predictions are not always correct. Even like we have the weather forecast. It helps you to plan what is going to happen. It helps to plan what is most important. I've had situations where, people have died, from maybe, for instance, a cancer, and a cancer that they actually battled with for years and years and years, 9 years on treatment, and then they died, and the family just didn't know what to do. Where does your dad want to be buried? No idea. What is his will? No idea. What was his wish concerning this? No idea. Because that aspect of the interaction, the conversation, was never on the table. Some people, they go abroad. Some people go, especially now with medicalization and whatever of care in a place like Nigeria. People go everywhere in the world. They go to, apart from going to the countries that, we always, knew that people would go to for care. People go, to South Africa, to India, to Ghana for care, getting towards, for care, because once there is an advanced disease and there is the chance or the possibility that curative care is not possible in Nigeria, then people bring money together and they want to fight, which is understandable. But in the process of fighting, also have a plan. God forbid, but if you get to India and something happens, what do you want to happen? Do you want to be buried in India? I've heard of people that will go to a country that they don't know anybody in, and then treatment, they're going back and forth, and then somehow they get stuck, and there is no plan, there is no conversation, it's really planning ahead. And dare I say that we should move away from that myth. There is an age-old myth that when you talk about dying, that it comes faster. Dennis, I'm sure you will be able to break that myth on this program, because you have been talking about dying for years and you keep flourishing, and you're even looking, you're looking lovely even just looking at you on the screen.
Don't use my own. Don't use my own, because my own, I started from the beginning and I prepared for that first. And I intentionally did that because I don't have high blood pressure. So it's easier. But it was easier for me to plan that way, in the sense that I didn't want my children to get sidetracked with what everybody else thought. There's no way I can sit down and say I have a stage 4 disease and I shouldn't be planning that. I shouldn't be aware that things can go wrong. And unfortunately, yes, I agree with you. People don't want to discuss. And it is a very hard discussion to hold. And it's a discussion that we have tried and we continue to try to bring up to the forefront, especially within the context of Nigeria, because we know that it can go wrong, and then many people have no plan, which is true. A lot of people don't know, and then you find, but you knew, you already knew, you were going down. Why didn't you do something? Why didn't you tell your children? Why didn't you? And then I don't know, but yeah, I'm sorry. I get sorry that things go like that. but sometimes I ask, why didn't you do the right things as well? Okay, well, I'm going to ask you a question. What do the government need to do to support cancer patients as they navigate this particular aspect of their journey? Because we look at it from the perspective of everybody has to do this and do that. But there are lots of sides, as you've said. There's the parent, there's the family, there's the hospitals, there's the patient themselves. But the government, especially when we look at Nigeria, have to contribute something towards this, because I know morphine is very expensive, and I know that's one of the drugs that's given out. But then it's because it's a controlled drug, it also has a lot of things that are aligned to it that don't allow you to access it, but they need to access it, and then people end up dying in pain and their dignity is lost, which is the one thing that bothers me the most. If anything else I can deal with, but that dignity of a cancer patient should not be lost in the process of all of this. What would be your own take on the support that a cancer patient needs to do to navigate this part of the journey, which is actually the most? And maybe give me one or two main things that we can take away from this, because it's very important that we take it away.
Thank you very much, Denise. So I'll say two things. One, the patients should be aware, the family should be aware, and while seeking treatment, even if it's in a private hospital, flag that word. We're getting more and more of that, even in the UK. Ask your doctor, ask your oncologist, ask the heart specialist, the cardiologist, I would like to access palliative care, because palliative care is growing in Nigeria. Yes, you have pockets. You have pockets of places where it is being delivered, and it's being delivered very, very well. Many of the teaching hospitals have, palliative care services. Some of the services have been privatized, but ask, because in asking, you will get answers. There is the Marcel Ruth Cancer Center, which is on the island in Lagos. It's a center that I'm not afraid of mentioning on this forum, because also it's run by one of our old girls, and I know that the care that is provided there takes into consideration holistic palliative care for patients that may need it. There are very, very brilliant centers. There's another center in Abeokuta that is linked up, and then of course you have centers that are across the country. In terms of what the government should be focusing on, Dennis, I believe that the government should be focusing on the policy, integrating the palliative care into the policies in the medical schools and in all of our hospitals, integrating holistic palliative care. One of the things that we have in Nigeria is care. So even if we are not able to fund, the expensive cancer treatment, we should be able to source care, good care, compassionate care. So the government should help. There are lots of charities that are doing small work, religious bodies. They should help to support this services. And lastly, but most importantly, as you have said, is making the medications available. Yeah, it's not just morphine. A lot of the medications that are required, we need availability, and that is also going to the talk about policy. We need availability. The World Health Organization has said symptom control is a human right. Pain control is a human right. So nobody is meant to be in pain as a human right.
Okay, thank you very much, Dr. Debo, for your time, and I want to take this opportunity to thank AIT for sponsoring this program. Let's talk about it. We'll be back in July, which is our Zoom event, and registrations will start later today. You can follow Common Cancer Foundation on our website, on our social media platforms, which is on our Zoom, on our Instagram, on our Facebook, and YouTube. You can find us anywhere. Ask your questions and try and connect with somebody that can guide you. Please always seek advice from people who can talk about what you're trying to do. Okay, not what you think is the issues. And we want to thank you, Dr. Ebu, for joining us this morning and for giving us your expertise on this topic as we hand it back to the AIT crew.
Thank you, Dr. Denise.
Thank you.